I'm going to introduce Dr. Petros Okubagzi, and he said to call him Dr. Petros. He is with the Clinical Trials Transformation Initiative and MedStar Health. And after his presentation, we will have time for 2 questions. So I'll introduce you right now, Dr. Petros.
Thank you. All right, how do I move the... Hi, I'm sorry. There was a little bit of a confusion earlier today. I was thinking my session was starting at 1:45. So I am based at the MedStar Washington Hospital Center, about 5 miles up the street. But I am proud to be a member of the Clinical Trials Transformation Initiative, which is the initiative that has been put together by the FDA and Duke and about 80 partners. The whole point of that relationship is so that we have a quicker, better access to clinical trial innovation without having one side going ahead of the other and the policies following the actual facts. As part of the work with the Clinical Trials Innovation Network, I have been part of the Mobile Clinical Trials Program, and one of the most recent parts of that Mobile Clinical Trials Program was the Engaging Patients and Sites group. And what this group did is we basically looked at what needs to be done as we do clinical trials in the future. With all this mobile technology out there, and we looked at the various ways that it's being used now and what our recommendations would be as a group. Basically, if you look at mobile technologies now, whether we like it or not, they're around, and they are a lot useful, but we need to have a certain way of looking at mobile technologies when it comes to clinical trials. Obviously, they are patient-centric. Everybody has a cell phone, or majority of people have a cell phone. They're efficacious in the sense that they are more reliable in terms of data being collected because they're done in real time, and they're very efficient because you literally can do your questionnaires lying in bed. So this was a survey that was done by CTTI in partnership with Vanderbilt. And what they basically were looking at was what the attitudes of patients, what the attitudes of physicians, and what the attitude of industries towards clinical trials. And this particular survey, I'm going to just highlight what patients had to say about clinical trials. One thing that maybe should be worrying the physicians in the group is that 76% of patients would prefer clinical trials. So if you actually look at the whole group, 84% of them are perfectly happy doing a clinical trial sitting at home and not going back to the doctor's office for their follow-up visits. It has its advantages and disadvantages, which I will mention in a little bit, but that was an eye-opener, at least for me. Patients also say that they were comfortable with the range of devices. All they needed to know was that it was simple to learn and use, and it was convenient in daily life, and they would like to see what is being collected in the machine. So we have tried to outline our recommendations into 3 major points. One is engaging patients and investigative site personnel early and often in planning clinical trials, selecting mobile technologies based on what the trial needs and not what you think the trial needs, and also conducting early feasibility and pilot studies to make sure that those mobile technologies are actually something that you can collect data on reliably all the time and also transfer that data into a database that you'll be using to analyze data. So I'm going to start highlighting the 3rd part, which is doing the early clinical trials. Just so that you know, as you plan clinical trials, if you're looking at mobile technologies, we have a link, the CTTI clinicaltrials.org. If you go there, you actually have an outline of what you need to do and what the group's recommendations are. So the first thing that we would strongly recommend is conducting feasibility studies. This is very important, especially when you have clinical trials that are looking at new devices. About 9 months ago, I went to see the Visiting Nurses Association at MedStar, and one of the things you learn is they have the Samsung phones that supposedly are good at taking pictures of wounds, and you're going to compare their different wounds. The problem with those devices, they need to have an internet access. And when you go to some of those patients' houses, the internet is choppy, and those pictures don't come in. So you have to try and test those devices in different settings and make sure that the data you're collecting is going to be reliable. The other thing is also that the more pieces you have, the more you test them individually, and also the more you test them as a group. Does one app go with the other one? Are you able to collect data from both apps at the same time if you need to? So some of those questions that we thought that would be relevant to people who are trying to implement a mobile clinical trial using this technology was that are also relevant patient perspectives sought after. One of the feedbacks we got was that patients were interested in data, but the people collecting the data seemed to think that they could get 6 things more than the 3 that the patients were probably, or we traditionally collected from. Because the more data you collect, the more work you're creating, the more errors people make. So you could actually affect your clinical trials adversely by collecting more data that you think could be interesting, but at the end of the day actually impacts your data. The other thing was how many of your patients can actually do what you ask them to do. This is an important question, especially as we look at disparities in healthcare, disparities in participation in clinical trials. We really don't want to exclude a group of patients just because they cannot participate in the mobile side of the clinical trial. And then the protocol elements have to be weighed against the potential additional burden. That is, in other words, the same point I was trying to make earlier, that you have to be careful writing your protocol and what you collect and how much work you're asking the patient to do. There's a little bit of considerations that you have to also make when you make your informed consents for those clinical trials. I'll just quickly touch on a couple of things. One is that we have to be cognizant about privacy risks and understanding, making sure that the patient understands that there's an element of privacy that's going to be gone as you participate in those mobile clinical trials, because there are more people involved in the process, not that people would be hacking it or what have you, which is another risk. But even having an IT support person being called because your device doesn't work is going to have another person into that loop that you normally wouldn't have. And you also have to be transparent about how confidential that data would be. Safety monitoring was another point that was raised during our recommendations. And the point there is that if you have devices that are collecting data continuously on a patient, what do you do with a patient who's now worried that, say, his weight has gone 5 kilos in the last 2 days, and this is a long holiday weekend? You have to be ready to address those issues and be transparent with patients that there may be times that there may be a group of people who are not going to be around to answer those questions. And then also establishing a language where patients do know who to call, how to do it when they come into the clinical trials. So this was an interesting part in the sense of what we think of confidentiality and what the patients gave us as a feedback on confidentiality. Now, this is a 180 patient participant study, so this is not generalizable. A national study may give us a different set of data. But on this particular study, about less than half of the patients were willing to participate, were not willing to participate if the data confidentiality was uncertain. I personally was thinking this would be closer to 80 or 90%, but I was surprised. 55% also said that they were not worried that other people, other than the physician, the clinical research coordinator, and the people involved in the trial would be able to see their data. About 62% also reported that they were comfortable or very comfortable using mobile technology that tracked their location in a clinical trial. It could be that people just assume that everybody's tracking them anyway, and that's probably why, but that was another interesting data we saw. In regard to the informed consent, I have touched on most of those, but those would be the essential elements that you have to add into your clinical consent. If you're looking at having them participate in clinical trials, you have to describe your technology in an 8th grade level. Data access and commercialization down the line with those clinical trials, a lot of people will be having access to those data, and you have to be trying to be as transparent as possible. And then what data are you going to be sharing back with the patient and the family? Safety monitoring that I have mentioned, data privacy, and then technical support and access. I'll come back to technical support and access. So the one interesting thing that I saw in this survey was that patients actually, even if they were given an iPad and they were asked to report something, if the iPad was not working, they would rather call the clinical trial nurse than the IT support line. So that adds another element to the complexity of doing those mobile clinical trials, because now the clinical trial nurses who normally interact with the patients would have to have a sufficient knowledge to troubleshoot those devices as they go about the participating clinical trials. And then they also need to understand that the in-person versus the remote communication methods are completely, well, they're not completely different, but they're very different in the sense that it's different to touch somebody's hand and see that it's cold versus talking on the phone and assuming it's cold or assuming it's warm or assuming a lot of things that a FaceTime chat would give you. Returning value to participants was another interesting part. Patients were very interested in getting the data live. If you're measuring their weight, they did not like that. They did not see what their weight was when they stood on the electronic scale and the app. Patients needed real-time data. And that's quite interesting because when you do a randomized blinded study, how do you do it? How do you do it if the patients really want to know what the results of that particular test is? There are other resources that we can also have available for you guys. If you're looking at this, again, it's the same website, the CTTI, and I have tried to abbreviate what's available there. Thank you very much for your time. This was the team that actually came up with the recommendations, and I would be happy to answer your questions. Yes.
Since we're hopefully in any kind of clinical study dealing with a diverse population, and we're talking about a medium that lends itself towards multimedia, I'm curious why the statement, an 8th grade educational level, why not relying upon video presentations of information, albeit in the material and issues of literacy?
So I don't think I understand. Are you thinking that 8th grade is too high a bar or too low bar?
There's nothing that appears. Sorry, there's nothing that appears in print that cannot be presented in a video format, more accessible to major portions of a population that historically has been excluded from a lot of studies.
Correct. So the 8th grade level is actually an IRB requirement. The majority of the IRBs require for it to be on the 8th grade level. Now, that is what's going to change with mobile technologies, because a lot of people who have less education would be able to navigate a cell phone, a web mobile app, and you're right. If it's video and you can do it in a way that's explainable. The whole point of that 8th grade level was to simplify things and not catch patients in medical lingo and not really inform them of what's going on. But I agree with you, the 8th grade level is an IRB consent requirement coming from the old IRBs and papers. But I'm sure that would change as time goes and we use more
They have verbal skills, but not reading skills.
I agree with you.
I hope you can answer this incomplete answer before dinner. But I work on the wearable artificial kidney, and we're going to have patients wearing it at home. How would you envision applying mobile technologies like the ones you describe to study a device like that, where people are dialyzing at home, walking around, we need to collect data, interaction with patients? And yeah, it's going to take you a little long, but how would you envision that?
It's not really a question of how do you envision it, or more a question of what do you want to collect. I think I like technology. Yeah, I like technology. I would be the first to admit it, and I get excited every time I see the next generation of iPhone. And my wife reminds me that what's so different about this one. But the point there is the technology should not guide what you're trying to collect. You have to have what you want to collect and see if mobile technology actually helps you collect it. I think the one thing that came back to us again and again is don't get excited about handing out the iPad. Make sure that the data you're collecting is what's making you give the iPad and not the other way around. Even when patient participation, you tell them there's an iPad, they'll jump onto it, not understanding that there's a lot of work in regards to that. So I'll give you an example. We have digital scales now. Actually can give you a daily weight measurements. I'm working on an app with Alexa, reminding patients to take their pill, make sure they put in their weight. There are different ways of doing it, but it all depends on what is it that you want to collect. And I would emphasize that that should be where you use the mobile technology and not the other way around.